Nós vamos agora beber na fonte do saber, da experiência, da vivência do professor Vallance-Owen, e que nos vai ajudar a subsidiar as nossas ações daqui para frente.
Bom dia. Like my predecessor, Bob, that's the only words I really have, apart from thank you in Brazilian, so I apologize for not speaking in your language today. When I came here, I knew that Brazil had a reputation for parties, and we certainly had a great party last night. I really enjoyed myself, and thank you very much to UNIDAS, to you, Madam President, Denise, for your hospitality. My daughter will be very embarrassed if she sees the photographs of me wearing my glasses last night. You know how daughters are. When their father even dances, it's trouble. Never mind wearing glasses like that. So I shall try and hide those pictures from her. It's wonderful to be here in Brazil with you today. And as you say, Chairman, every healthcare, well, maybe your healthcare system has some problems, but I don't know any healthcare system in the world which doesn't have issues and difficulties, especially with the funding issue. We're all under huge challenge of funding problems, and there is a lot to do for all of us. So I've been asked to talk to you about the British healthcare system. I don't come here saying it's any better or it's any worse. It is another system which tackles things maybe in a slightly different way. But we're certainly not here to say, that we are any better than anybody else, just as Bob was saying the same sort of thing about the United States system. We have the same challenges. So just very briefly about me, I should say that I'm a doctor, I'm a surgeon. Originally, I moved into medical management. Some of you may have heard of the international private healthcare company in the UK, Bupa. I was the chief medical officer of Bupa for 16 years. I retired last year from Bupa, and I'm now very much working in healthcare still in a range of areas, but particularly working partly with the British government. And I really am wearing the hat today of the medical advisor, the senior medical advisor to Healthcare UK, which is promoting and working with other countries in terms of sharing what we can do in our healthcare system and learning from those countries too. So that's a bit about me. What I'm going to talk about, as it says here, is a bit about the National Health Service, how we do things. A bit about primary care, which I think is really important, the gatekeeper role, which I'll talk about, which I know is of interest to you here. Private healthcare, there's a big debate about the role of private healthcare in the United Kingdom compared to the public system, again, as there is here, and it may be that there is some interesting perspectives there. And then I'm also a little bit at the end going to talk about private-public partnerships, particularly in terms of building new hospitals, building new facilities, where there has been a very strong partnership over the last few years. So that's what I'm going to cover. Oops, wrong way. Sorry. And of course, because I'm speaking, as it were, on behalf of the British government, my slides, of course, are very positive about the National Health Service and say all the good things about it, as you might expect. If one of your government speakers was here, they'd be doing the same thing. But I will, of course, try to talk about the challenges and the difficulties as well, so that you understand that. So the National Health Service, as you may know, was founded way back in just after the Second World War in 1948. And those are the main principles upon which it is founded. It will meet the needs of everybody, every British citizen. We call them subjects because they're subjects of the Queen. Every British citizen is covered by the National Health Service. It's free at the point of delivery. You don't have to pay when you go for healthcare. Nobody has to, except for prescriptions for drugs where there is a small charge, but not for people with chronic conditions who are old, who are young, so they don't raise that much money from it. And that it is based on clinical need, not the ability to pay. These are founding principles, and they are very much still the situation now in our National Health Service. But of course, it is under pressure because of the funding issues which have hit our country and many others during this recession. The NHS faces similar challenges, as I've already indicated, to a lot of countries around the world. Huge growing expectation from consumers, from patients, with Google and all the sort of Twitter and all these sorts of things. People increasingly come to the doctor's surgery, with a whole lot of Google papers telling the doctor what they should do, and that's going to increase in more and more. And actually, like Bob, who was speaking earlier, I am absolutely convinced that change is most likely to come in healthcare, not from top-down reform, but from bottom-up patient power. I think the more patients are informed, the more they have transparent data available to them to help them make choices about which treatments, about which doctors, about which hospitals, the more they will get involved and they're empowered. That will be what will drive change, perhaps less than top-down reform. And I think they are absolutely at the centre, or should be at the centre of everything we do. But the second challenge, maintaining the quality of services when there's ever challenging funding issues, of course, is really important. And of course, in the UK, we have a huge growing elderly demographic. And that, of course, is bringing all sorts of new issues. Bob again was talking about, in a way, the failure of some prevention and the need to really address at source before the situation gets worse and worse. We are suffering, as I'm sure you are, as it get older, even if our children may not be so old, huge numbers of chronic disease. And we still have a model, as I'll say later, where most treatment is done in hospital, very, very expensive, as Bob said, where we really need chronic disease to be managed nearer home in the community. And that's a huge challenge. So just the principles of our National Health Service system. We think primary care is absolutely fundamental. As in the United States, about 75% of the money is spent on hospital care, and only 20 or 25% is spent on primary care. But actually, it's that primary care which is a crucial part of our healthcare system. And doctors these days in the community, in primary care, have been put more in charge of spending the money, commissioning healthcare. So their role is to understand the needs of the patients in their local population, acting together, to understand what is possible clinically and financially, and to commission care, to purchase care on behalf of the patients, which hopefully will drive higher quality. But the crucial thing is that they are able to say which patients should be referred to a hospital and which they will continue to look after. Patients do not have access directly to hospitals in our system. It's the convention, it's been understood for years, and even in the private system, the insurers require a GP, a general practitioner, to have signed off that referral into the private system. It's a very important part of our efficiency, I think. Obviously, we're trying also, though, on the provider, when I say the provider side, I mean the hospitals and clinics, obviously very much trying to, by better regulation and pricing, drive a value service. Value is outcome, clinical outcome over the cost. And the regulators are both financial ones to try and ensure efficiency, but also quality regulators to try and ensure best outcomes against best cost. And that's the value equation, and we're all, in all our countries, trying to get best value for our healthcare. And there is a degree now of competition within the provider markets between the private hospitals and the public hospitals. I'll come back to that again later, which has led, that sort of challenge has led to some increases in efficiency and, in fact, in quality in both sectors. And then, crucial in terms of long-term investment, again referring back to Bob's talk just now, the whole question of public health, health promotion and prevention, which, as in other countries, has not been given the investment that it should have been over many years, and we really have to tackle that issue. So we aim, and this is one of those slides which I said is produced by, for us to promote our system. These are our aims in the National Health Service. I don't say that we're achieving them yet, but these are the targets. And it is very much to put patients and the public first. Always think of the patient first. It comes back to my point about informing, empowering patients. Offering choice with information, with decision aids, which help them see the difference between treatments, to enable them to have an informed discussion with their specialist, with their doctor. An information resolution to make revolution, to make sure that they can see that information, have access to it, and a strong public voice through an organisation we call Health Watch, which is part of the National Health Service. And that's a real driver, and that is a real driver. It's not there yet, but we have a long way to go. The next one is very much, as I've just said, about improving outcome. We are increasingly an outcome-based service. For too long, cost, price, money has been very much the driver in our healthcare system, and to try and balance that, we're now concentrating much more on outcome. And on my next slide, I'll show you the framework which we're using to measure performance of hospitals as well, and our healthcare system as well as cost. And of course, using organisations like NICE, the National Institute for Clinical Excellence, to help us give best practice, to decide where is the evidence base, and to work with the evidence base to try and reduce clinical variation, which is huge in our country, and I'm sure it is here, to reduce it to a more reasonable level. And obviously incentives these days for quality as well. And then finally, the whole question of accountability, a degree of autonomy, but accountability for professionals, for doctors, for nurses, to make sure that they have the freedom to act professionally, but within clear professional rules of engagement. And as I said, this bottom thing, separating doctors who are treating patients one-to-one in primary care to actually purchasing the care on behalf of patients. It's a bit of a distinction, if you like. I just want briefly to mention this outcomes framework. The whole of the National Health Service now, and the private sector too, is being measured against this chart, if you like. There are 5 domains, as you can see there, of outcome. The first one, which is all about preventing people dying prematurely, is very much what Bob was talking about. How are we doing in preventing illness and promoting good health? The second one, enhancing the quality of life with long-term conditions. So often we talk about alive and dead in our data that we collect. You know, if you die, mortality rates are really given huge importance, but only a very small number of people actually die in our system, and your system too. The great majority live, and alive or dead doesn't really give you much distinction about quality of life. 95% of people probably live, but that's not good enough. We need to know that they live a good life and have a high quality life, especially with chronic conditions, where it is the most important thing, I think, to patients themselves. Helping people to recover from episodes of ill health. We are increasingly, and this is my world, I started this in the United Kingdom, measuring patient-reported outcomes. Clinical doctor outcomes are not enough. They have a bias, maybe. you'll attack me for saying that, but of course there is a bias there. Asking the patients routinely whether their health status has improved by measuring their health status before treatment and after it is giving us hugely valuable information, which to add to the clinical information. And then a positive experience of healthcare. Were they asked questions? Were they given the opportunity, choices about different types of treatment? How were they looked after? And then safety is the last one. So our sort of new defining characteristics which we're trying to work towards in the healthcare system are these. Universal, it was always universal, and we're very keen to keep it universal. It is a hugely large publicly funded health service. I think we have 1.3 million people working in that health service, and we're very keen to maintain the principle that it is open to all, funded by the taxpayer, open to all, free at the point of service. When it comes down to providing the service, that's where the private hospitals and the public hospitals are competing, but the fundamental model remains a universal one. Very much trying to make, despite that competition, to make it a more integrated service. There has been the hospital service and the primary care service and community services sitting in the middle, very much in silos, and we're very much trying to encourage greater integration, which gives better care to patients and makes the whole thing much more efficient. And then organized, especially through better data collection, so that we really understand in real time what is happening to our patients and getting their feedback, as I've said. That we have a long way to go on yet. It's an aim, it's a target. I'm sure we're all working on that ourselves, and better systems of regulation. So our key building blocks, if you like, are infrastructure and facilities, as it says there. And I'm going to come back to how we've done that later on when I talk about private-public partnerships. Better facilities, better data infrastructure. And that's the bottom one, compatible information systems. We have multiple systems, different systems in our hospitals. Each hospital may have a different one. In primary care, we have different systems. We're very much trying to get a more integrated approach, always bearing in mind the big issue of patient confidentiality. And I think we're very much trying to work through that so that those who are purchasing healthcare, the commissioners, can access much better data to inform those decisions. And then training. As you see, we proudly say we produce top-class clinicians. I'm sure you produce top-class clinicians as well, but clearly training the right number of clinicians and the right number of nurses at the right level with the support staff is very important. And traditionally it's been the doctors over here and the nurse training over there, and planning, workforce planning is becoming much more of an issue. Do we really need as many general practitioners seeing patients on a daily basis, a very expensive resource, when nurses, pharmacists could do much more in primary care? And increasingly we're finding emergency medical practitioners who work with the ambulances are actually treating a lot of the emergency calls, the 111 calls, 999 as we have in the UK calls. They're treating them at home, they're able to prescribe, and 60% now of those emergency calls don't lead to an admission or a trip up to the accident room. And obviously technology, continuing our work in bioscience, in our research, for which, again, we have a strong reputation. Just quickly, I don't want to go into the detail of this, but I think there are some differences with the system that we've heard about in the United States. A population of 62.6 million. Our per capita spend per head in dollars, in US dollars, is $3,480 per year. Our management costs are very low, at only 3% for this public system. If I can just say, sorry, let me just go back. our GDP percentage is 9.6%. I think the American system is near 18% these days, and we feel that we provide very good value for money as a healthcare system with our strong outcomes, but managing on 9.6% of GDP. I give you some idea of some of the statistics. And 8,400 general practitioners in primary care, really important part of our service. This is a busy slide. It tries to explain, we've had so many reforms over the last few years. I think there have been maybe 10 or 11 reorganizations of our healthcare system since I started not that many years ago. This is our current version. As I said, this is the, I always press the wrong button here, sorry. This is where the money comes from, the Department of Health, the government, the Treasury, from the taxpayer. And the commissioners are the people to whom the money goes primarily, and they have to decide how to spend it, to assess the needs of their population, and then to spend it on the hospitals that are going to provide the care. And then we have regulators and watchdogs who very much try and drive the safety agenda and ensure, as I say, monitor, looks at the financial side. The Care Quality Commission looks at the quality side, and getting the value, again, is outcome quality over cost. Complicated system, but that's the essence of it. But this bit, as I say, spends 75–80% of the money, which is something we have to tackle. The types of service, well, I'm sure you have the same system here. Tertiary specialist services, very rare conditions, rare cancers, only a very small number of patients needing to go to highly specialized units or hospitals. Our main hospitals in the middle, with expertise in a whole range of conditions. Maybe we have now too many hospitals as more and more patients are being treated as day cases or outside hospital. But every time we try to reconfigure, as the phrase is, or close a hospital, there is a huge outcry from politicians who don't feel that should be happening in their local community. And then, of course, primary care, looking after being the direct place where the population go first for their treatment. And I'll talk a bit more about primary care a bit later. Oh, no, in fact, it's now. And so the focus is very much on primary care still in our system. The first contact for new health problems, you go to your GP or your family nurse or your family pharmacist first, before you go anywhere near a hospital. 90% of the health problems are dealt with in primary care. The minor ones, the not so minor ones, and an awful lot of prevention and promotion is done there too. And as Bob has said, a key area which I have argued, like you, Bob, for many years, is we should do much more in the workplace. A captive audience, and there is evidence that really doing this sort of work in the workplace drives huge dividends. It's very positive, and we need to do more in that area. Patient-focused care, long-term conditions shouldn't be dealt with in hospitals. You know, you should be able to deal with those things routinely, apart from the complications in primary care, and that's what we do. And of course, care coordination and access to the secondary care, as I say, through that gatekeeper model. And these are all the things which I've just said, really, which are going on in our primary care system. Health and well-being should be central to that, and they are increasingly incentivized in our system. We actually incentivize our primary care system to do immunizations, to do tests on blood pressure and those sorts of things. They are given extra money for doing that, to give them a positive bonus for promoting health in that way. So a lot happens in primary care. You know, as I said, 90% of the episodes are dealt there, and these are all the sorts of things, really, which are going on there. Really, it just reiterates to some extent what I was saying earlier. And primary care is not just the primary care physician, not just the general practitioner. It's all these people. These are all people who work in the primary care team, including what we would call social care for people who aren't medically ill but need care and attention. The elderly, obviously, particularly come into that bracket. Does primary care work? Well, we think it does. I've got about 4 slides like this, but I wanted to show this one because this is international comparisons. And it definitely shows, as it says in the red box there, that experience, those patients in the countries who have a primary care orientation experience better health outcomes and incur lower healthcare costs. That's the value equation for you. And we think our system is very important in doing just that. So, effective primary care can do these things. If you haven't picked these points up already, I'm sure you'll be able to read them there. But it's all part about gateways to hospital, sometimes a path to the hospital, sometimes saying, look, we can do better here with self-care or working with you in the community, and cost-effective care, promoting healthier lifestyles. So that's the National Health Service system. I want to talk now about the sometimes parallel but increasingly integrated private healthcare system in the UK. Now, remember, all citizens are entitled to the National Health Service. Everyone is entitled to the public system. So private healthcare is supplementary. People who buy health insurance, as you can see, about 9% of the private cover in the country is through health insurance, are topping up their public cover by buying health insurance. Health insurance isn't comprehensive. It essentially covers secondary care only, and there is a small international market in London, and 3% of the population have self-pay private procedures. That particularly covers cosmetic procedures. The National Health Service won't cover any cosmetic procedures except following cancer, breast reconstruction and things like that. So there's a self-pay out of your own pocket market because insurers won't cover cosmetic procedures either. And we divide, because of the complexity of the system here, we divide the market, if you like, into 4 boxes. As you can see, first of all, though, on the right, let me just go back. On the right, the NHS-provided admissions, elective admissions, by far the majority are done in the National Health Service. And we have these 4 boxes. Along the 2 on the top are where the NHS, the National Health Service, is funding the treatment. So this is the normal National Health Service system. And this is where the National Health Service is funding a public patient in a private hospital. A public patient in a private hospital, which is increasingly happening. So an awful lot of patients now who are in the National Health Service are being treated in private hospitals as part of this competition at the provider level. And on the bottom you have the private side, private funding of NHS provision. So some National Health Service hospitals have some private wards, some private wings, mainly for the more complicated care, but not always. A very small percentage are in those PPUs, 0.8%, but some public hospitals do have some private patients. And then this is where private funding, insurance, or people who are paying for themselves are working wholly in private hospitals. So it's getting quite complicated, and there is a degree of competition there now. I mean, just for your interest, as it says there, the privately funded number of cases is about 650,000 a year, about 350,000 are now funded by the National Health Service in the private hospitals. This just gives you an idea of the names of the various hospitals, the number of private hospitals across the country. The reason for absence in these areas is because they're very rural. There isn't much private work to be done. I don't know if you can see it, but the light green is National Health Service patients, the proportion, and the dark green is purely private patients. It's just to give you an idea. And then here we have the sort of where the main private patients are, were the ones who are insured, who are adding to their cover by buying health insurance. And as you might expect, it's in the main areas of the big cities, London, Manchester, Birmingham, Glasgow. That's where you would expect, I think, to get the main private sector patients. And this is just the division for interest by the different private hospital groups who have a degree of competition across the country. And you can't really see this slide. This gives a breakdown of the types of patients by different sector. So this is the National Health Service patients. These are private patients, and these are patients who are being funded privately in National Health Service hospitals. This is age 0 to 103. And I just tell you that the light blue here is, and this is male, this is female. The light blue is knee arthroscopy, very common in the National Health Service, but also in the private patients as well. The bright red is cosmetic procedures. So this is privately funded patients. In the females, these are probably mainly breast enlargements and so on. It gives you the breakdown of the different types of conditions over age. It's very interesting to look at who does what where. This is the power of data. So why do people buy private care when they're entitled to the full range of the National Health Service? And these are the reasons. It used to be reduced waiting. We used to, and I think that's probably an issue here too, and in many other countries, some patients used to have to wait nearly a year, say, for a hip replacement because of the demand. And one of the things that the last Labour government under Tony Blair did was to bring down the waiting times. And so there is now, strictly speaking, under this government it's gone up a bit, there's meant to be you can't wait any longer than 12 weeks. And that has all sorts of problems with the medical profession because they sometimes find that they're doing what they think are non-clinically urgent cases in order to keep under the 12 weeks. But so people were buying health insurance, particularly companies were buying health insurance to get faster speed of treatment, less so now. But also the facilities tend to be more modern. Obviously a customer focus. These are private sectors. If you lose a customer, you lose money. Public service isn't quite the same. So these are the reasons why people pay quite a bit more, but maybe only £2,000 a year, 6,000 Brazilian money, for their premium to cover health insurance for a year. So looking at the insurance market quickly, I think it's maybe the same here. The business customers, which are divided into large corporates, about 35% of the insurance market is large corporate customers, 35% is small, medium-sized business who believe it's worth buying for their employees this extra cover, particularly for speed of treatment. And then the personal customers who are buying it for themselves, as I have to, now that I'm not employed anymore, 30%. And the business model is that the business customers, because they have the power in the market, they get very big discounts. And so the reason why insurers want a lot of business customers is to get volume, to have leverage with the hospitals that they're negotiating with. And the personal customers provide margin. They haven't got the ability to negotiate discounts, and that's where the income comes from, the surpluses come from. So you'll see there the providers. My own company, Bupa, has 40% of the insurance market, and then quite a lot of smaller providers who are out there. In terms of the providers, the hospitals, there are about 200 private hospitals across the country. I showed you a map earlier on. They're quite small. Actually, 100 beds is probably large. They're probably more like 60 to 80 beds per private hospital. They're quite small institutions. They're doing cold elective surgery, not doing the major stuff, except some very big ones in London. That's our standard model. And but the hospitals are regulated by the Quality Commission, just as the National Health Service ones are, to get a quality comparison. And then there's a lot of very small providers who are not regulated because they're not doing medical treatments in the strict sense. So that's particularly cosmetic treatments like Botox, injection of fillers, cosmetic treatments with lasers, that sort of thing. And then the specialists, the doctors, who are the third part of this market. Most of them work mainly in the National Health Service, but do some sessions every week in the private sector. Some of them are full-time specialists in London, but usually they work in both sections, in both sectors. And they're independent practitioners. They're not employed by the hospitals. They are independent in those hospitals. So that's a bit about the private sector. Just before I go on to the private sector partnerships, the competition that was introduced by the Labour government, when the Labour government came in, all the NHS patients were treated in NHS hospitals, and all the private patients nearly were treated in private hospitals. And what the Labour government brought in was no change to the principles of the NHS, but at the hospital level, they encouraged private hospitals to start offering treatment to National Health Service, to public patients. And this caused a huge controversy in the country because this had never happened before. So there was now competition between private and public at the provision of care level, not at the funding level. And actually, those private hospitals did a very, very small percentage of private work when they were brought in, but it had a big effect on the attitude of the National Health Service hospitals. They had not been competitive. They had been just getting on with their own thing. And having a little bit of local competition, taking some patients away from them, certainly led to quite significant change in thinking, in efficiency, in driving quality of care in the National Health Service. And it is still very controversial, and there are politicians who feel that it's a disaster and that we're going to lose the principles of the National Health Service by having a private involvement in it. But I don't take that view. I think bringing in a little bit of competition to enable private providers, not only in hospitals, but in community services, even in primary care, is actually helping drive a better attitude, a better customer focus, and better outcomes, actually, across the whole of the service. But it does remain very controversial, this more integrated approach, and you may have some questions for me on that in a minute. And then just finishing quickly on private-public partnerships, and this is more about building, about the private sector working with the public sector to build hospitals, to build clinics, to fund clinics, and this sort of partnership has been going on for some time. Sometimes it's outsourcing a service, so provision of your pharmacy or provision of other services by the private sector. It might be cleaning services. Those are the easier ones because they're not clinical services, through contracts, and then more complicated partnerships, which is building and designing hospitals and financing them, and that is very much a long-term approach, as I'll show you quickly. And it is about partnership. The whole point of a partnership is that agreements are between both parties and have a mutual agreement, mutual responsibilities for both parties. So if you're going to have this sort of commercial partnership in the public sector, if you like, it's really important that everybody agrees what are the goals, that they are realistic, both sides agree to them. You have to know who is doing what in which side of the partnership right at the beginning. There have to be clearly benefits for both parties. It's not just for one, it's not a win-lose. This has got to be a win-win arrangement. The discussions have to be open and honest. And there needs to be a degree of equality of participation. It's not just handing over to the private sector. The public sector needs to be very engaged in the discussions as the plans go forward. These are the basic fundamentals of these partnerships. I mean, this is the example. It's rather a strange example, but it's the only photograph I could have of a new hospital, Moorfields, a very famous eye hospital in the UK, which was built by a partnership between private money, private capital, but provision of services for public patients. And the main one I'm going to talk, there are various types of things. The main one I'm going to talk about is the top one, the Private Finance Initiative, which is really about financing capital investment to enable you to build hospitals. So these are long-term financial contracts, maybe 25 to 30 years long. And payments only have to be made by the public sector if the private sector is sticking to the agreements that it made in the original contract. There are some other smaller arrangements for instance, helping primary care clinics build and one thing and another. I won't go, they're similar in some ways. I think I've run out of time, so this is just an example of one. I'll quickly move on. So we've been using this system in the United Kingdom for some time, introduced in 1991. 130 now of these major private partnership projects in the country. About £12 billion worth of capital value has come to enable quick build of hospitals, which the government could not have afforded by itself without these arrangements. But it's very costly. 12 billion amounts of capital raised, so that's raised now to build a hospital now, but it ends up being paid for over 25 to 30 years, so the total cost, like a mortgage, when you borrow money to build a house, is much, much higher. It costs the health service 79 million over 25 to 30 years, but it enables that capital to be raised to build hospitals. So there are various big building partners and design partners who they work with, and it can be building contractors. The whole range of facilities can be provided. And this is the sort of way in which it's divided up. The public sector commissions the facility, it says what it wants, it pays for those facilities over time, and the design and the build and that sort of thing is done by the private sector partner. I'm not going to go into I've got a final, you've got these slides in your pack. I just want to talk about the pitfalls, just in case they're not obvious. It's obviously a very rigid approach, but if you have proper partnership, it can work very well. Variations to contract over time can be expensive, and the whole thing over time is expensive, but it does enable, as I say, beautiful hospitals to be built here and now, which could not have been built by the public sector with the lack of money that they have. And here's an example of one. This is the Queen Elizabeth Hospital in Birmingham, which was built entirely through a public-private partnership. So finally, just the advantages and disadvantages there for you. Access to capital. The risk gets transferred from the public sector to the private sector. The delivery is much, much faster, much better organised. But the disadvantages are there. It takes some time to set up, and the lifetime cost is high. But this has worked very well in our country, and you may be already doing it here. So, my last slide. I come from Healthcare UK, from the government. We're very happy as an organisation representing the Department of Health in England and the UK Trade and Investment, the government, to try and introduce you, if you're interested in any of the things I've said, to introduce you to services. If you want to come, we'll set up meetings for you, introduce you to the right sort of people, and provide expert advisors and speakers if you're at all interested. And we are as interested to hear what you do in your country, to come over and tell us about it, as I hope you might be interested to come and talk to us. So thank you very much indeed. As I've said, the healthcare system in the UK is not now just the public sector. It's very much a system with many partners, private and public, very different to what it used to be. Thank you.
Excelente. Muito obrigado, Dr. Andrew.